Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy.
Who's doing? I got this first case. I think I'm presenting one. I'm ready.
You ready?
Give it.
All right.
I think so.
I'm going to try and find this. I had a TMJ case as well, but I think somebody else had the floor.
Said,
Yeah,
hey,
am I able to?
how are you?
What's up, Carla?
How's it going?
It's going well. What up, Reed?
What up, man?
We got that coffee.
I was so close to just going back to sleep. So close. So close. I think I'm just gonna make myself like a coffee and put it at my
Can you guys see my screen?
Yeah, you can see it.
Okay.
Yeah.
All right. So who's taking this case?
Oh, I signed up for the first one. So you want to take this one or the next one?
You tiger or you turkey?
If you eat enough turkey, man, turn into turkey.
Yeah, you already mentioned.
Ready?
All right.
Okay.
All right.
All right. So this is your case. So 39-year-old female presents to your office with referral from a general dentist that over the weekend she suddenly developed a difficulty opening. What would you like to know?
So I'd like to know preceding history. So I'd like to know
trauma.
Hey, can I pause this for a second? Colin, are you hearing
Yo.
that? It's like a 3-second echo. I don't know what it is.
Sounds good. All right. So you were talking about loading with tongue depressors. Tell me again what that is trying to distinguish.
we're trying to separate the muscular component from the joint inflammation and pain in the joint.
Okay. All right. So do you want any other studies at this point?
Yes, just a screening panoramic X-ray.
Okay. Basically, her pan looks relatively normal. She has slight flattening of the superior aspects of the condyles, but otherwise no bony abnormalities. What other changes would you expect to see in someone with chronic TMJ disease?
You mean on the imaging?
Correct.
If there is erosive changes to the joint, we'll see an interruption of the cortex of the condyles and possibly fossa. I will see some subcortical lucencies and irregularities of the shape of the condyle with bird beaking.
Okay. So why she asks you why her X-ray looks normal, but she has this terrible pain in her joint? What's the reasoning?
So we could, I would tell her that pain could be associated with soft tissue dysfunction. Her muscles or fascia could be the cartilage, it could be the disc in the joint, could be inflammation within the capsule as well that are not ever visible on the X-ray.
Okay. So during your exam, you kind of ascertain that when you place the bite sticks on the left side and she bites, she has terrible pain on the right. At this point, do you have a diagnosis for her?
Yes, I would give her right masticator myofascial pain as well as right TMJ disc displacement without reduction.
Okay. How did this happen? What's the etipathology of anterior disc displacement without reduction?
This could be chronic trauma from overuse that allowed laxity of the retrodiscal tissue that would allow the disc to slip forward.
Okay. How does a lateral pterygoid come into play?
Lateral pterygoid muscle attaches to the neck of the condyle, and part of it is attached to the capsule in the discal region. So straining of that muscle could produce some abnormal anterior displacement.
Okay. How would you like to proceed with her?
I would begin this patient on non-surgical therapy for 2 weeks, which consists of non-chew diet, anti-inflammatory medication, and warm compresses to the area.
Okay, she comes back 2 weeks later and there's no change.
If patient has been, I'm going to check for compliance with the regimen. If she has been compliant, then I would suggest then next point of escalation, which would be arthrocentesis of the right TMJ.
Okay, discuss your consent for that procedure.
I will tell the patient that this is a procedure that will be done in the office under sedation. It will involve flushing of fluids through the joint space that is expected to help her improve the symptoms. However, there's no guarantees can be made in that. There's a small risk of infection and bleeding associated with this procedure, as well as risk of fracture of instruments inside the capsule. She will be swollen and somewhat more painful for the first few days, at least after procedure, but that's expected to resolve because of the fluid accumulation.
What's the thought process behind arthrocentesis? Why is it performed?
Arthrocentesis is thought to decrease amount of inflammatory factors inside the joint capsule.
Which inflammatory factors?
There's the basically degradation products of arachidonic acid, which are cause the tissue injury inflammation.
Are there any in particular that have been studied?
Can't remember off the top of my head right now.
Okay, so during arthrocentesis, you get your first port in, you feel like you have rebound, and you're trying to get your outflow port into the superior joint space, but you're having trouble. Why do you think you may be having trouble?
You saying my outflow port is in, it just I'm not getting outflow out of it? Is that what you're saying?
Yeah, you're not quite sure if you're in, you're not getting outflow.
Okay, all right. So the outflow port is most likely in the wrong position, where it's not inside the joint space.
Okay. Is there any particular place that you might be able to put it if you can't get one in the anterior aspect?
I would basically try to adjust, have somebody hold the inflow port in a position that I find is appropriate, and then do very small, tiny movements to try to point my outflow port as close with its tip as possible to the inflow port.
Okay. What are you going to do once you have outflow?
I will perform irrigation of the joint with at least 120 cc's of normal saline.
Okay.
And then after that,
when you're done
I
with
would
that,
instill, right, and after that, I would instill a Kenalog 40 milligrams suspension.
why would you put Kenalog?
It's the thought is that Kenalog would prevent, again, breakdown of the arachidonic acid that will then result in block, basically, generation of further inflammatory factors in the joint.
Is there anything else you could put in?
There's nothing else that I typically put in a joint space.
Okay. So while you're trying to get that second outflow track in, you were mucking around for a while. As you pull it out, you realize that the tip of it looks a little bit funny. It looks like it's a little shorter. So what do you think happened?
So I would suspect a fracture of the instrument inside the joint space.
Okay. What are you going to do?
I would perform a CT scan of the area. If I have a CT scan in the office, so just confirm that by getting CT scan to see what the location of this tip is.
Okay, you see it on the CT scan. It's kind of superior medial joint space. It's about a 4 millimeter length of the tip of the needle. What do you want to do?
So then the scan confirms location of the instrument inside joint space. I would discuss this complication with the patient, explaining to her that this is something that I would recommend removing under general anesthesia in a hospital.
Okay. Walk me through that. Patient's prepped and draped on the table.
I'll make 3 centimeter preauricular incision right in front of the tragus, taking care to stay about a centimeter, no more than a centimeter from the external auditory canal. We'll use a Bowie to go through the skin and then through the underlying cutaneous tissue and through the fascia until and taking care to retract the superior temporal artery, then hit the zygomatic arch area, incise the periosteum, perform subperiosteal dissection, retract the soft tissue flap anteriorly, and then locate the joint capsule just inferior to the zygomatic arch, and incise, make a vertical incision into the capsule, and carefully retract and enter the joint space to locate the instrument.
Okay, so you see the instrument and you retrieve it. Now, given the patient's diagnosis beforehand, is there anything else you're going to do while you're in here, or are you just going to take out the instrument?
So sure, I will examine the location and condition of the disc while I'm in there.
Okay, so the disc is anterior displaced. You can see it ahead of the condyle. Grossly, there's a small 2 millimeter perforation in the disc. What are you going to do?
Well, I will take note of that. That this disc is most likely not salvageable, and I would then close the incision, and after patient wakes up, discuss the findings with her and advise her. I will advise her that there's a possibility that this disc may need to be removed in the future if her symptoms do not improve with conservative therapy.
Okay, so you talk with the patient now. She's pretty upset that now you're going to have to go back into the joint and take the disc out, but you're now going to go back and you're planning on doing a discectomy. During your procedure, there's significant bleeding. How are you going to start to control it?
So I will determine exactly where the bleeding is coming from. Is it coming from laterally to the joint, or is it coming medially from the joint?
It's coming medial, and it happened right as you were taking the disc out.
Okay, so I will suspect that if it's medially, then it's middle meningeal artery, or masseter, or maxillary artery, internal maxillary artery.
Okay, well, she's bleeding a lot on the table right now. What are you going to do to stop it?
So I will apply the sustained pressure, manual pressure, for about 5 minutes and reevaluate.
How are you? Is this digital pressure? You're just pushing into the joint, or what are you doing?
I'll take some gauze packing and put that right over the spot where there's bleeding, and then put fingers over that.
Is there anything you can do with the mandible to help with this?
Yes, I could go ahead and close the mandible into occlusion.
Okay. So the bleeding is not stopping. She's lost about 1 liter of blood. What do you want to do?
So I will discuss with anesthesia for arranging for blood transfusion, and I will also call in interventional radiology or vascular surgery to perform emergency angiogram of the external carotid artery to evaluate where the bleedings come from and possible embolization.
Okay, so your IR suite's full. They're going to be there another hour and a half. They tell you. What are you going to do?
I will determine if my digital pressure is enough to control the bleeding while I'm holding it.
Her blood pressure's 90 over 61 right now. Heart rate's at 135. You've hung 1 unit of blood, but it's not responding.
Well, in that case, we will have to proceed with ligation of the external carotid artery on the left side.
How do you do that?
It will have to be submandibular incision in the neck.
Briefly discuss how you get down to the carotid.
Sure. It'll be about 4 centimeter incision that's parallel to the left sternocleidomastoid skin with blunt dissection through the underlying fascia and retraction of sternocleidomastoid laterally, and location of the carotid sheath, and careful vertical incision through the carotid sheath, and locating of the carotid artery and just clamping.
Okay, you found the bifurcation. Where are you going to tie it?
We will tie the the lateral branch after the bifurcation, which is the external carotid.
So you're going to tie off the whole external carotid?
Well, that's what's going to control the bleeding. Yes.
Okay. All right.
Again, tied.
Well,
I mean, like ligated, with vessel loops temporarily at least, so we can hold pressure on that with a hemostat or something.
Sure. Okay. All right. Well, the patient, you get the bleeding to stop. Then the patient goes to IR. They embolize the middle meningeal, which is where the bleeding is coming from. And she wakes up. She's okay. Post-op, she seems to be doing all right. Except she has this weird feeling that now when she eats, she feels like her face starts to sweat.
Okay, so I would suspect Frey's syndrome to be happening.
And what is that?
Frey syndrome is malconnection of parasympathetic fibers from parotid gland to the skin sweat glands.
What nerve is involved?
That's parasympathetic to the gland.
What?
Parasympathetic nerve to the gland, which is 9.
Okay. What is there a specific test that you can do to diagnose her with Frey syndrome?
Sure, we could use a starch test, which shows if there is a if there is no, I gotta take that back. We will just basically get her to bite a little bit on the lemon and see if there's any sweating going on in front of her ear.
Okay, so she has She has the auriculotemporal nerve syndrome. So you're going to treat this. What are you going to do?
What typically is required to delineate the area that's showing the subnormal.
Hey yo, I gotta sharpen my swords for the oral boards. I learned them from Patel and he's the Lord. And I'm his protege, you know I'm gonna slay all these motherfucking questions today. Cause I got the sound bites, they're gonna make these old men go ooh, ah, like some afternoon delight. Yo, I got these questions in my sight and I got the answers. Yo, my answers is so ill, they give you canker sores.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.